Okay, so any questions we were talking about blood pressure, we're talking about regulation of cardiovascular flow yesterday. Any questions about that? Start out with. All right, we're going to continue on talking a little bit about hypertension. This is going to be a huge thing that we are trying to treat in a large number of our patients. It's a chronic problem, leads to lots of issues, cardiovascular disease, MIs, all kinds of bad things. You'll notice that we have the JNC8, I don't remember what that stands for. It's like Joint National Commission on Hypertension. Basically, they come out with guidelines regularly every few years, and so we're on the 8th edition of that now. And basically, they'll say here are the goals to get to a safe blood pressure based on really very large studies that looked at thousands of people, saying okay, if your blood pressure is maintained at this level, this is the safest thing for you. At least those are your goals if you're treating hypertension. And so you'll see things like it can be based on the age of your patient. So obviously, as you get older, people are just likely to have their blood pressure kind of go up just naturally as the aging process happens here. And so you may see that there's different goals, so that a patient who's like, say, 20 years old is going to have a little bit stricter guidelines than someone who's, say, over 60. Notice here how they like you to have a blood pressure less than 140/90 or less than 150/90. This used to be a little bit more strict back in the day, but they're starting to see they probably don't have to be quite as strict with the blood pressure goals in those situations to get similar kind of good mortality outcomes. But you can see that certain disease states will also predispose you to bad outcomes, and so we also want to have a little bit more strict control on their blood pressure as well. So things like if you have diabetes, right? So that stands for diabetes mellitus. Most often type 2 is what we're referencing there. And so we'll say, okay, well, they also should have less than 140/90 because of the fact that they have blood pressure issues, they have cardiovascular issues to go along with their diabetes. We should keep their blood pressure in control. CKD, you guys know what that stands for? Yeah, so chronic kidney disease. So that's another one where, again, oftentimes high blood pressure can lead to chronic kidney issues. So it's kind of a chicken or egg kind of scenario. Diabetes is also going to shred the kidneys. So a lot of these things kind of interplay with one another. And it's not uncommon to have a patient who has kidney issues, diabetes, and hypertension all at the same time. And you can see kind of what their goals would be based on this. Okay. You actually get to the goal. Some of the other causes you can see for hypertension, having kidney disease. If you're not forming urine appropriately, you're not getting rid of that volume, you'd have increased preload or afterload. You'd have increased volumes, you'd have increased preload coming back to the heart, so that could lead to hypertension. Sometimes you end up having renal artery disease, and you have secretion of those vasoactive chemicals. So like renal would be one of those big chemicals we talked about yesterday. Yeah, so you can end up seeing that kind of feedback and causing that to occur. So oftentimes patients will have issues with both preload and afterload. It's just sometimes you'll have one that kind of gets more accentuated than the other. So for instance, a patient who has an acute kidney injury where they're anuric now, they're not making any urine, they would have a definite preload problem because of this build up all this fluid. Eventually that could lead to hypertension as well, which can also be an afterload problem. So these are very much intrinsic, but it's important to make that distinction when you're trying to solve one problem or the other. Things like diuretics, things that make you urinate more, are going to fix one problem versus another. Right? It has a lot more issue to do with preload than it does with the afterload. So we'll look at that in more detail in just a second. A lot of endocrine issues that can occur here. So if you had like tumors in the adrenal medulla, so you can have like a pheochromocytoma, you're releasing too many catecholamines, causing your blood pressure to be high. Nervous system issues can crop up here, and things like intracranial pressure increases. You see this a lot after traumas or patients who have had certain strokes. They're starting to have issues with their pressure building up there. And then even issues with the cardiovascular system. So certainly we see issues with things like patent ductus arteriosus. Do you guys know what that is? Basically, a hole in the heart in fetuses that allow for blood flow to occur. Because again, when babies are getting blood flow, where's it normally coming from? Come from the mom, right? So it's all coming from the umbilicus. And so for those patients, they need to have holes in the heart that allow for good flow to occur. And if they don't have, or they have those holes stay there after they're born, and they should have closed, the circulation ends up getting mixed. That means that you have venous blood being sent out through the arterial system or vice versa, and depending on the malformation, and they can end up having to work harder in order to pump oxygenated blood to the body. So that can be a big issue there. Yes, ma'am? Yeah, so patent foraminovalia is going to be a different condition, but similar issue that can happen there, where they can have mixing of the blood and the heart has to work harder. Yeah. So you also have issues like coarctation of the aorta. You guys know what that is? What is that? has like a narrowing of the aorta, right? So that can impede blood flow. All that would lead to an issue with preload or afterload. That would be afterload, right? Because you're having to pump harder against that to try to get that same blood through the aorta there. Or if you had arteriosclerosis of the aorta, all that would narrow that down and lead to have higher pressures there to try to force that blood through in appropriate amounts, right? So you can kind of see like, okay, is this a preload issue? Is this an afterload issue? Vice versa. Obviously, anemia can be a problem here, hyperthyroidism, hyperlipidemia, so lots of different things will contribute to this. You guys will run into this more when we get to your CMS classes and we talk about it in pharmacology. Let's see. Most people probably fall into this issue of essential hypertension. Again, it's going to be difficult in a lot of cases to determine what's going to be the one single thing that caused your patient to be hypertensive. In all likelihood, there's probably multiple things that are causing this. So whether it be lack of exercise, or if they have low potassium, or stress issues, or they have increasing cortisol expression because they're really stressed out all the time. And lots of different things can be involved with this, but essentially you try to fix underlying issues where you can, and where you can't, we use things like medications to help directly affect the cardiovascular system. So the big problems we worry about, see issues like blindness. So if you're constantly having high blood pressure there in the retina, that can lead to issues where that nerve can be damaged, lead to blindness. You can have kidney failure, can develop from this, heart failure, heart attacks that can actually occur. So lots of different problems we worry about. So this is why we try to prevent that ventricular overload that happens there. Basically, you have remodeling that occurs over time. So the ventricle is always trying to pump harder than it really needs to because of either an afterload or preload issue. You're going to see that remodeling where it gets more stiff, it becomes less compliant, can't really have that nice stretch like we're used to having, and that can lead to chronic issues, usually CHF being one of the big manifestations of that. So again, high blood pressure bad, we want to fix it. We'll see how we can do that in upcoming classes. Just so you know, some of the meds that we use most commonly, so things like diuretics can be very common ones. So you guys have heard of HCTZ or hydrochlorothiazide. It's a very common hypertension med that we'll use for some patients. That's a diuretic, meaning it will cause you to urinate more, try to get rid of some of that salt and some of that water off the system. You will have things that will affect specifically the sympathetic nervous system, right? So we'll have drugs like clonidine that will shut down the sympathetic outflow, so that way you can see decreases in blood pressure and heart rate that come about from that. We can have drugs that specifically block certain receptors. So we have things that block beta receptors, like atenolol. That's a beta blocker that will block beta-1 receptors on the heart, and that will lead to, what do you think it would do to heart rate? Slow it down, right? So you slow down the heart rate, maybe not having as high as pressures there, and that can lead to reductions in blood pressure. We also have things that are direct vasodilators, so things that actually come in and relax that smooth muscle, either on the arterial side, the venous side, or both, and that can lead to big reductions in blood pressure. We mentioned minoxidil before. You guys remember that drug? Where is that known as? Rogaine, yeah. So it originally was used as an antihypertensive, but realized it was not very good as an antihypertensive because it caused patients to bottom out. So we didn't like that, but we now use it on our heads most often. I guess you could use it other places, but I've not tried. I actually don't either route, but one day I might need to. You have things like calcium channel blockers. We said calcium is really important for causing smooth muscle constriction, right? When you have calcium entering into those cells, that allows that sarcoplasmic reticulum to release calcium, which causes actinomycin to kind of come together. By blocking that calcium influx, you can actually end up preventing that smooth muscle contraction, and that will lower blood pressure as well. So lots of different routes we can go to, and oftentimes you're going to run into cases where I need to use a thiazide diuretic plus a beta blocker, or maybe using a calcium channel blocker plus something like an ACE inhibitor that will prevent the effects of angiotensin II. A lot of times you have to mix and match drugs to get your patients to their goal blood pressure. Okay, and obviously there's going to be all side effects associated with all of these, and so it's a really careful game to play to see, like, okay, what's best for my patient, what's going to get them to goal, hopefully they're going to have the best long-term outcomes for them, right? So, any questions on that? All right, everyone seems pretty. So we're going to move to the immune system, how we can fight off infection, how we can deal with that. So we'll talk about various hematologic components of the immune system. We'll also talk about some of the innate immunity that we have as human beings, and then talk about some of these components and how they get associated with the immune system in general. So we'll talk about these defense mechanisms. We'll talk about our B and T lymphocytes, active and passive immunity, a little bit about tumor immunology, and then some interactions that can occur here. All right, so first off, talking about defense mechanisms. So what are kind of the main components of our immune system that we have? How can we fight off infection? So we have our white blood cells, and we said that what are the main components of our white blood cells? So we said our granulocytes and our agranulocytes. Which one would be considered agranulocytes? Monocytes and lymphocytes, right? So little monkeys. And then our granulocytes would be never eat bananas, neutrophils, eosinophils, and basophils, right? So those are the primary components there. You're going to see that they have very different actions within there, talking about what specific type of immunities they're going to be involved with. But again, keep in mind they're all coming from this kind of multi-potential, this pluripotent stem cells, and they'll either end up coming down this kind of myeloid progenitor line or the lymphoid progenitor line. Again, if you think about like your leukemias that can occur, you can have lymphoid leukemias versus myeloid leukemias. So you ever hear like AML versus ALL? Those would be the differences in the cell lines that end up kind of growing out of control in those cases. Also, this is where you're getting your platelets from, as well from those megakaryocytes. Again, a lot of our cells are going to end up becoming from the bone itself. Sometimes they're precursors that end up being processed in other organs, as we'll see in just a minute, but some of them will be produced directly in the marrow there. So, we have, when you get down to talking about the lymphocytes specifically, we'll talk about our cell-mediated immunity and also our humoral immunity. And if you guys could describe the difference, would you guys know? Cell-mediated versus humoral immunity. Yeah, so think about, when you think cell-mediated, think about T cells. We'll talk about T cells that are directly going and either directly attacking a pathogen, whether it be bacteria or virus, or some helper cells that can kind of help out in that process. And then you'll have your humoral immunity. It's not very funny, but this will be responsible for releasing a lot of like antibodies and things like that that will help to kind of cause this interplay between the T lymphocytes attacking some of those pathogens. Sometimes you'll see that the antibodies help to either directly neutralize a pathogen, right, by binding them up and causing agglutination and things like that. Sometimes they're going to help to signal other molecules to come along and start to phagocytize some of those cells there, right? So lots of different interplays that can happen here depending on if you're dealing with a parasite or a bacteria or a virus. We'll see some of those interplays and how those actually work. But think humoral immunity, think your B cells, think antibodies. If you're thinking your cell-mediated immunity, think T cells. Think about helper T cells, natural killer T cells, things like that. Notice they're both coming from these hematopoietic stem cells here within the marrow. The T cells are going to be processed within the thymus. We'll talk about that more in detail in just a little bit, but this processing here is super, super important to make sure that we are able to differentiate ourselves from foreign material. Okay, so we run into issues where if we were to have, say, like a thymectomy, you may have some issues being able to actually differentiate between, your own natural cells versus foreign cells that come in. And when you have problems where your immune system is attacking your own body, what do you call that? As an autoimmune condition, right? So that's where you have things like rheumatoid arthritis come about. You have things like lupus, all kinds of different autoimmune conditions that can come about when your body's not really able to tell the difference between itself and foreign material. Okay, so again, we'll talk about two main types of defense mechanisms. We have our innate or non-specific immunity, and then we're also going to have this adaptive immunity. And so you're mainly going to see that the humoral and the cell-mediated immunity is going to be this adaptive immunity, because this is going to be against specific pathogens or against specific targets, usually against specific antigens that you're going to find. So think about antibodies, think about your T cells. That's going to be adaptive immunity, because it's not something we're born with necessarily. It's something we're going to develop over time as we get challenged with some of these different pathogens, right? And we have innate immunity, which are going to be kind of non-specific immunities that we inherit just as being a human being. We have things like our skin that can be a protective barrier against bacteria, or our GI tract, or different things like that. We'll go into some more detail on those, but keep in mind there's two very specific types, and know which ones kind of fall into either subset there. Okay, so talking about innate immunity first. Again, think about things like internal and external forms of innate immunity. External ones being things that prevent the bacteria or the pathogens from getting into the system in the first place. Things like the skin. The epidermis is a nice kind of thick layer of material to prevent things from getting in. Unless you have some kind of break in the skin or a wound or something like that, that can be a major site for infection there. Also, some lysozymes that will be situated within the dermis itself that will allow for destruction of bacteria should they cross over. The digestive tract was really important for the acidity in the stomach, because that helps to destroy a lot of the bacteria as well. We know our intestines are riddled with the bacteria, but they're mostly going to be the helpful variety in most cases. But when you're ingesting, say, foreign, potentially dangerous bacteria, the stomach acidity is usually pretty good to destroy that. We run into a lot of problems with this when we have patients who are like in the ICU, and we worry about them having stress ulcers in the stomach, where the stomach acid will actually burrow through the gastric intestines. So we'll give them drugs that reduce that acid producing capability. We'll give them drugs that will basically shut down the ability to produce acids. And then the next thing we have to worry about, especially if they're ventilated, right, they have an endotracheal tube in, is that they will start to produce these bacteria. They'll start to grow in this now non-acidic environment, and they can translocate over into the respiratory tract. So the big issue we see with those patients is ventilator-associated pneumonias. You'll learn lots more about that as you go forward. But again, that acidity is critical to try to destroy a lot of the bacteria that are coming in through the GI tract and through our food and things like that. You also have the respiratory tract. We'll have the alveolar macrophages that are there. They can help to get rid of a lot of the bacteria that may be depositing itself within the lungs. And we also mentioned we have the ciliated cells, right? Those are meant to try to, we have a lot of mucus as well. They can help to get rid of a lot of that crud that comes in through the respiratory tract. So all those ciliated cells help to kind of beat together to move things towards the pharynx, so you can just swallow all those delicious bacteria and then break them down for protein, right? That's essentially what you're doing. So it's a lot grosser when you say it that way. But and then internally, you're going to have a lot of different either chemokines, or you're going to have these cells themselves that are going to be useful. So you can have phagocytic cells that will be either just directly engulfing bacteria or toxins that can neutralize them. So think about things like your macrophages, think about your neutrophils there. You have certain interferons. These are going to be molecules that are going to help to basically kind of help stimulate the immune system. They also help to kind of protect cells that may have not been infected by a virus yet. Talk about natural killer cells. These are going to be cells that are already kind of made with the capability of targeting foreign products, even though they haven't really been sensitized to it, like some of our T killer cells we'll see in just a little bit. And then also mast cells can be very useful for releasing a lot of the mediators that we'll see when we have an inflammatory reaction. So we'll look at that more in detail a little bit later on. But histamine is going to be a big product here. Mediators of inflammation like prostaglandins and things like that will be formed from these mast cells. Yes, ma'am. You have to speak up. I can't hear you. Yeah, so we'll talk about chemokines as being kind of a generic term for some of these molecules that will help to influence other cells within the immune pathway. So you're going to find, especially like your T helper cells, they release a lot of things like interferons, and you'll find that you have things like granulocyte, macrophage, colony stimulating factors, and all these different things that help to influence either chemotaxis, which will be the kind of signaling to draw more white blood cells into the area of infection or inflammation, or to help kind of differentiate some of these cells into new products, or to stimulate formation of some new products. Yep. Okay, so again, this table is kind of just nice to show you again some of the different external and internal kind of innate immunity that we have, just natural defenses that we are just born with in a lot of cases. We run into problems in many cases where patients may have either congenital issues, or they have some disease state which will make them much more likely to have failures of these external defenses. So for instance, if you have a patient with diabetes and they chronically have high blood sugar, do you think bacteria like to eat sugar? Absolutely, that's their main food source. They love to eat that. So when you have patients, especially some of the diabetic patients, they can have issues with genitourinary tract infections because the urine is high in sugar content. May actually overcome some of these defense mechanisms and lead to increased risk for infection, right? Or if you have things like skin breakdown. So having wound infections is a huge thing we like to prevent, and having good wound care for our patients is super, super important. Especially if you think about patients that are laid up in a hospital bed for a long period of time, what do you end up having develop? They end up having pressure ulcers. That can be a major site for infection. Those are no good. So that's why you always want to make sure you're rolling your patient, every so often, to make sure they don't have those develop. So. The internal wise, we already mentioned some of these already. Complement proteins are going to be another major one of our internal kind of innate immunities we'll talk about later. These help to be activated by some of our other kind of learned immunity cells, but these can be activated all on their own. But these help to enhance that inflammatory response. Certain natural killer cells I mentioned, mast cells. So again, all of these are going to be useful. We're all kind of born with these. All have them at baseline. Okay, so the main types of phagocytic cells we're going to have include our neutrophils. Oftentimes, these are going to be in the highest concentration, just circulating in the bloodstream. You guys remember kind of the normal constitution of, like, the percentage of neutrophils in the bloodstream? Yeah, 60%, right? So those are going to be floating around the bloodstream. Those are the most numerous you're going to be able to get a hold of in a very short period of time. Now, they're not going to have quite the same ability to neutralize as many bacteria as something like a macrophage, which is a larger molecule, can engulf a lot more of these bacteria. But the neutrophils are nice because they're present, they're available, they can just respond pretty quickly in a lot of those cases. Those monocytes, which eventually turn into macrophages, will arrive in the blood a little bit later. They're not going to be quite as numerous. They start to get, once they get that signal that, hey, there's an inflammatory event happening here, they'll get kind of drawn into that chemotaxis. And then some organ-specific phagocytes, you're going to have things like macrophages or certain specialized cells that will exist in places like the neurons, or will exist within the lungs and the liver. They live in those tissues for a good long time. They can stick around for much longer than they would in the bloodstream, but once they get activated, they can then kind of unhinge themselves from wherever they're located at in that tissue, kind of migrate over to the site of inflammation, and then kind of kick off that with the neutrophils. Okay, so kind of three main ways that we're going to try to get these phagocytic cells involved, so we can start to engulf these bacteria or these viruses, whatever happens to be, and start to break them down. Are you guys able to hear me okay? Okay. So again, neutrophils, you're going to find these mainly in the blood. They'll also be located in a lot of tissues, kind of ubiquitous throughout the body. Monocytes mainly circulating around in the blood. They will again respond to areas of inflammation, but not be the first responders in those cases. Those tissue macrophages I mentioned, that's where you can find things like in the spleen, the lymph nodes. They're kind of living there in that tissue. Again, they're not as quick to mobilize, but they can respond kind of to local sites of inflammation by starting to migrate to that area. Talk about specialized cells like the Kupffer cells live in the liver. This is really important because we mentioned that things that get absorbed from the GI tract, what's the first organ they hit? It's going to be the liver, right? So this is really important for destroying any of those bacteria that may have been, survived through the stomach, gotten absorbed through the GI tract. You can end up destroying them there in the liver. Alveolar macrophages are super important to make sure we keep the lung a sterile environment. Once you have destruction of these, or they're not functioning as well, lots of pneumonias can develop from this. And the microglia, which we'll find in the central nervous system. So just some slides. Again, you're not going to have to recognize these on a test for any reason, but just to kind of show you some different places they're going to show up. There's how things like the alveolar macrophage are going to kind of just be hanging out there. They can live there for months to years in some cases until they detect there's some site of inflammation. They get activated. They're going to kind of unlock themselves from this position and migrate over to that inflammation, engulf whatever it can, and then kick off the rest of the inflammatory cascade. Okay. I mentioned the interferons. This is primarily going to be involved with antiviral activity, so fighting off these viruses. We have three main interferons that have been identified. So alpha and beta, they inhibit actual assembly and replication of the viruses. So you prevent that, you prevent new viruses from being made. And then also the gamma interferons can help to fight certain infections. It may be also useful in helping to suppress certain tumor cells. We're starting to see more drugs being developed that are basically kind of recombinant versions of these interferons that we're actually producing ourselves. I don't like them a lot for a lot of the side effects that they cause. It's very interesting how for things like hepatitis C, we would use interferons for a long time to treat those patients. It's basically the only drug we had, but it caused major psychiatric changes. Patients would get very, very aggressive or angry or depressed, all kinds of problems with it. So we don't like to use these if we don't have to, but it may be one type of drug you'll see being used. It's the gamma is probably going to have the most activity there. The alpha and the beta are going to primarily be focused more towards viral replication. Yeah. Okay. So then moving on to the adaptive immunity that we have. And again, adaptive just means what? It's a learned immunity, right? So we're developing against specific sort of stimulus there. When we talk about like vaccines, that would be adaptive sort of immunity, right? This is something we would be challenging ourselves with the vaccine in order to develop new immunity to that. We'll talk a little bit about vaccines and some of the different ways we can actually stimulate our immune system. Again, I don't know what anyone's stance is on vaccines, but I will take a steadfast pro-vaccine stance here, so come at me, I guess. I don't know. We'll talk about it. At least we'll talk about the mechanisms for how they actually work. We can discuss side effects and things like that later on, if you like. Anywho, So again, these adaptive immunity, it's going to be acquired ability, right? So we're having to develop it after the person has been born to defend against these specific pathogens and exposure to those pathogens, right? Mainly it's going to be involving our B cells and also our T cells. Again, think about B cells primarily going to be releasing antibodies that can help to either signal that, hey, these bacteria need to be taken care of, or they can actually neutralize it itself. And then also the T cells, which either can help to stimulate the inflammatory system. They can directly damage some of these bacteria and pathogens. So, but again, they have to be targeted against specific sorts of pathogens. And the main things we're going to be looking at is going to be the antigens and antibodies. We kind of covered this already a little bit when we were talking about blood types, right? So again, antigens are going to be things that generate an immune response or generate antibodies at least, and antibodies will be the things that actually respond to that. Okay. Do you think we can use antibodies as drugs? Yeah, actually we do. If you ever think about like snake antivenom, that is actually antibodies we've produced from either like horse or sheep in a lot of cases that directly neutralize the venom from the snake. So to keep that in mind, that like we can actually use antibodies as therapeutic molecules we can actually give patients, but there's going to be some inherent risk with that, because again, anytime you're giving foreign proteins to a body, guess what? That can now act as an antigen. So antibodies can themselves be antigenic in some cases, but basically, we'll see that the B lymphocytes are coming directly from the bone marrow. You're going to find that they don't really have a processing area like the T cells do. Interesting, you guys know where that B comes from for the B lymphocytes? You think bone. I thought bone too for a good long time, but I was actually reading...
The chicken thing.
Yeah, it was a bird. Yeah, the bursa something or other in a bird. So basically we discovered B cells in a bird first, and then some particular organs like the bursa forma something or other. It's very scientific, but that's where the B actually comes from. So it's not bone, but bursa. And basically they're going to be combating bacterial and also some viral infections based on the antibodies that they're going to be generating here. Basically, you're going to find that once they have been targeted against a specific pathogen and they get activated, they're going to be releasing these antibodies through a process we'll talk about more in detail into the blood and also into the lymph tissue as well. Right? We know the lymph tissue is going to be a major site for infection fighting as well, because where a lot of kind of excess fluid and products get processed through the lymph system. They have a relatively short lifespan. We're going to look at the memory cells and how we can get some extra utility out of those, but they're not going to live forever. Right? So this is why you can actually lose immunity to things over time in some cases because of the fact that these are going to have a relatively short half-life compared to something like the T cells, which we're going to look at. But again, there's going to be our humoral immunity or the antibody-mediated immunity, okay? Because they're specifically releasing these antibodies. They're not actually that cellular immunity because they're not really directly targeting the pathogens themselves. Yeah, so in humans, it comes from the bone marrow. That's how it's actually made. But when we originally discovered it, a lot of things get named based on where we discovered it at, and sometimes it wasn't in humans. This was actually in a bird. But again, the B does not stand for bird, it stands for bursa, some particular organ we saw in these birds. So someone who has an immunology background could probably tell you more than I. Anyone that does have an immunology background, if I say something dumb, correct me, as always. So again, when you're developing these B cells, you're going to note that they will have one specific target. B cells are really kind of one-trick ponies, and when you're looking at them individually, they're only going to be targeting, say, you know, the flu, or it's going to be targeting one pathogen only. So when you have an antigen that's going to come along and bind up these antibodies here that are located on the cell surface, this is when they end up getting activated. Some portion of these cells end up getting differentiated into what we call these plasma cells. Plasma cells are going to have a large amount of antibodies that they can release, and these get sent out. They can then bind up whatever antigens that are present, and then at that point you can find that they will either make them a little bit more, you can find that the complement system gets activated from this. Sometimes that it will cause what we call agglutination, where the antibodies kind of surround and kind of neutralize the bacteria, and they'll kind of form a clump that occurs, the way that makes it easier for them to be phagocytized. Or just make them kind of just targeted for other cells to come along and kind of chew them up. So again, the plasma cells are going to be the kind of the main things that are releasing antibodies here. We'll also talk about memory cells, which are also going to be produced in some proportion here, and those are what's going to help to leave you with a little bit more kind of a long-term kind of immunity to a product.
The antibodies will be towards that antigen, right? So
yes.
That antigen is found on any other pathogen that's kind of similar. So
yeah, so sometimes there can be like a little bit of interplay between like the the presentation of the antigen. So like if you're like looking at like a polysaccharide or something that's on a bacterial cell wall, there could be a little bit of changes in there that it may still recognize. It depends on whatever the actual binding or what it is actually binding to, you know. But that's why we have things like when you look at like the pneumococcal vaccine, like we have like a 23-valent pneumococcal, because the pneumococcus bacteria can have so many different antigens present. By targeting 23 different ones, you can actually end up having much better immunity to it, as opposed to just looking at one antigen that a pneumococcus may or may not actually express. Because I was talking less? Oh, sorry. Yeah. That's fine.
Not your fault.
No, that is my fault, but please point that out. It's good to know. Right, so again, we have the B cells. They're being developed in the bone marrow, right? They're going to be coming out, and then we'll look at how they develop their specific target, essentially. But what you're going to find is they're going to have one specific antigen that they will respond to, right? They have antibodies located on their cell surface, and when they get targeted, or when they end up binding to one of these antigens, they're going to go down this differentiation pathway. The B cells themselves are not super potent at releasing a ton of antibodies, but what they do is they can be developed into, or differentiate into, these plasma cells. We'll look at that again in a second, but plasma cells release a lot of antibodies. That's what's actually doing the kind of the business end of that immune response. There are also going to be some memory cells that get formed as well, which are going to be useful for when you end up having re-exposure to that pathogen again. They will be able to respond better, and that's how we kind of have, you guys know, like when you get immunizations, you get several doses over time. That again is to challenge those memory cells, and that's why there's going to be minimum time frames between when you can actually get some of those vaccines, to make sure that you have a good, you generated those memory cells, you can re-challenge them, you make more of them, and re-challenge them again in some cases, to make sure that you have really good full long-term immunity against some of those products. And then sometimes with some of those vaccines, you may have to get a booster several years later in order to make sure you can re-challenge the system and maintain the ability to respond to that. Okay, so if you think about things like your tetanus booster, you know, if you have a significant other or yourself gets pregnant, they recommend getting pertussis, getting vaccinated against that, because again, getting a booster, getting re-exposure to that can help to prevent things like whooping cough in infants, right? So that's kind of the process we're seeing happen here. The T lymphocytes, on the other hand, they end up getting produced within the bone marrow, but that's not kind of their final spot for processing. They're not really ready for showtime at that point. So what ends up happening is they get sent over to the thymus, where they can differentiate into their kind of full-fledged differentiated T cells. The interesting thing with the thymus is that it's one of its main duties is to make sure that the T cells are not going to attack your own cells. Right, so they will be able to test a T cell, a kind of a fledgling T cell, test it to see if it's going to react to a human or one of your self antigens. If it does respond, they get rid of that T cell. They just go ahead and destroy it. Once it's able to show that it's not going to react to your own cells and it is targeted against whatever specific target it has, then it can be released out into either like the lymph tissue. Some of it may be circulating in the bloodstream, but a lot of it ends up in the lymph tissue as well. But this is why we have issues to where if you were to bring in someone else's tissue into your body, for instance, you were to transplant, say, someone's liver or their kidney or their heart, that's why the T cells are attacking that, because it is recognizing those proteins or those antigens as something foreign, and those T cells are going to want to attack it. And so how do we deal with that? Yeah, so we do some matching to make sure that the patient's not going to have like a major rejection of that organ, but then we also follow up after we actually transplant it. What do we do? Yeah, we do immunosuppressants. So we do things to actually tamp down that immune system to make sure they don't actually have a reaction to that. But of course, when you affect, you know, it's nice that it helps you to prevent rejecting that kidney that got transplanted, but what else does it do to the patient? It affects the entire immune system, so it also makes them more susceptible to infection. So that's one of the huge things we ran into. So we would have patients, we'd have hem-onc patients. So a patient had leukemia, got basically they did radiation and chemo to basically wipe out the bone marrow, and then got a bone marrow transplant. Okay, so basically they were able to take a compatible donor, they took bone marrow, was able to inject it back into the patient, and that was supposed to hopefully repopulate their body with non-cancerous white blood cells, essentially, right? But in order to prevent that rejection, to get rid of that bone marrow, we end up having to immunosuppress the patient with lots of different drugs that can do that. And so then they end up getting super sick from follow-up infections, and then that's potentially what kills the patient, right? So again, it's always a double-edged sword when you're dealing with things like, you know, transplant and things like that. That is interesting. Maybe there was a little bit of some learned immunity against those cells, and maybe that's what caused eventually to not, that caused the first one to be unsuccessful over the long term, and then maybe when you re-expose the body to that, they were able to have a stronger reaction. I'm not sure. There's certainly people that specialize only in transplant. I mean, there's even like transplant pharmacists. That's all they do. So someone that specializes in that might have a little bit better answer for you. But right, so T lymphocytes are very good for attacking things like host cells that have been infected with either like a virus or like something like a fungus, transplanted human cells, and also some cancer cells. We'll see that can be very useful for, and in some cases we can actually use certain products or certain drugs to actually target these T cells to attack cancer cells. So for instance, if the cancer cells express a certain protein that non-cancer cells don't, we can potentially target that and cause these T cells to preferentially destroy them rather than keep your healthy tissues safe. So, but again, this is called the cell-mediated immunity. Notice the T cells do not produce antibodies. They may have some interaction with antibodies, but they themselves do not produce any. Okay, so again, just a nice chart that kind of shows some comparisons between the B cells and the T cells. So the site where they're processed, mainly B lymphocytes are going to be in the bone marrow. The thymus is going to be the final processing point for the T lymphocytes. Again, these are going to be humoral immunity, which means they're secreting antibodies for the B lymphocytes, versus the cell-mediated immunity. Looking at the subpopulations, mainly you're going to find memory cells and plasma cells. So again, plasma cells are going to be the thing that the B lymphocytes get differentiated into that will release a lot of the antibodies. Memory cells are what are going to stick around after the initial challenge in order to respond to subsequent challenges, right? Versus the T lymphocytes, you're going to find we have our cytotoxic or killer T cells, our helper cells, and these are going to be really important for helping to attract other inflammatory cells to the site. And then we'll also have some suppressor cells, which can help to hopefully tamp down some reactions to our own self cells in some cases. Looking at surface antibodies, you're going to find that B lymphocytes can have IgM there, or IgD in some cases. We'll talk about immune globulins in just a few minutes. These can be expressed on the surface here versus T lymphocytes. They do have receptors for some of these antigens, but they're not really considered to be immune globulins like you would see on the B lymphocytes. But again, both are going to be present and able to, basically like for the B lymphocytes, they have surface antibodies. They're the same antibodies they'll eventually end up releasing versus T lymphocytes. They just have receptors that can be responsive to a specific antigen. We'll look at what some of those look like in just a few minutes. The T lymphocytes stick around for a lot longer, in some cases months to years, versus the B lymphocytes have a relatively short half-life. Which is why we need those kind of use those memory cells and kind of re-challenge them to make sure we can keep those sticking around. And then if you're looking at where they are distributed in the body, you're going to find a high amount within the spleen for the B lymphocytes, a low amount in the blood, depending on if you have an active infection or not, and then high amounts of T lymphocytes in the blood and also the lymph. So a lot of them like to hang out in the lymph tissue, where they can just respond to any kind of passing by antigens that may be getting processed through that lymph tissue. There's a lot higher percentage of T lymphocytes we're going to have expressed at any given time, so about 80% versus only, say, 15 to 20% here in the B lymphocytes. And then, again, I mentioned the B lymphocytes, when they get transformed by antigen, so when they have exposure to that antigen, they get converted into plasma cells versus just activated lymphocytes. Really, so no change in the actual cell itself for the most part. As far as secretory products go, B lymphocytes will release antibodies. We'll talk about lymphokines in just a few minutes, but lymphokines are going to be these kind of helpful molecules that mainly get released from the T helper cells that will help to attract other cells to the site of action. So this will be things like interleukins. We'll talk about interleukins. Those will be really important for helping to establish and kind of propagate that inflammatory reaction. And so you can see some of the different conditions that you can have immunity to based on whether it be certain viral infections, bacterial infections. So usually you'll find the B cells are kind of targeted against one particular pathogen versus T cells will have a different kind of subset of pathogens that they're responsible for attacking there. Any questions on that? Yes, ma'am. Memory cells are B cells. They're still considered B lymphocytes. It's just that's what's that is going to be another byproduct when they get activated through their antigen. So we'll look at that in detail in a few minutes. They'll still probably have a similar lifespan, but it's just that because anytime you are challenging those B lymphocytes with an antigen that it responds to, some subset will get turned into those plasma cells so it can respond and neutralize that threat. Another subset will turn into those memory cells, and that's what kind of sticks around for later exposure again, right? It's not like days or anything like that, but it just depends on the B lymphocytes. Some of them will stick around for longer than others, but that's why you can, for some things, like you'll have lifetime immunity to it. Sometimes you're only going to have kind of a short-term immunity. That's why you need those booster shots. Well, some of them, like, that's true, like the T lymphocytes. So since the T lymphocytes stick around for longer, like lifetime immunity may be more seen with those. Again, I don't have the numbers on the lifespans like right on top of my head, but it's in the book, so you can always look that up and check that out. Yeah, so T lymphocytes, they're still targeted against a specific pathogen, right? So they're always going to be, say, if they are targeting, say, leprosy. If you've gotten some exposure to leprosy before, you're going to have some T cells that are going to be targeted against just that. And so they can go through, and next time you're exposed to it, it'll be able to attack that a little bit better, and you can have some degree of immunity against that. Yep. So again, these are both learned or adaptive immunities. They're all targeted against specific pathogens individually. Okay, so looking at the lymphoid organs, looking at the lymph tissue that we've been alluding to so far. Not going through this very fast, so it could be running out of time here. But anyway, so the lymphocytes we can see derived from the stem cells in the bone marrow. We mentioned that some of these cells are going to go to the thymus, like the T cells there. Some of them are going to hang out in the spleen. B cells like to hang out in the spleen there, and then also in the lymph nodes. And again, the bone marrow and the thymus are considered as primary lymph organs, lymphoid organs, because that's again where you're going to see the majority of those white cells being produced there. So we're going to have lymph nodes located throughout the body. The spleen is another really important place for processing some of these potential pathogens. The tonsils are another site, although those are probably most likely vestigial because you can remove them and still not really have a lot of problems with infections. We also have these Peyer's patches, which you can find in the mucosa of the intestine. Those are also useful for starting to target some of the pathogens that may be absorbed from the GI tract, so that can kind of help the liver out when it gets, eventually those cells get presented to those Kupffer cells. And then basically they can help to capture and present the pathogens to the macrophages. So essentially you're going to find that you're going to have certain cells which will capture these pathogens, will start to break them down, and they can present some of these antigens on the cell surface that will activate things like macrophages and start to activate them and get them targeting that whatever the pathogen, the challenge may be. And so they also are going to be primary place where the lymphocytes are going to be living, especially those T lymphocytes. And you can find that they can migrate between the lymphoid organs or to the blood. They can transport themselves as needed to wherever the site of infection might happen to be. I mentioned that the spleen is a really important place for filtering the blood for pathogens. This is where we run into issues with certain patients who may have functional asplenia. So asplenia would be basically if you didn't have a spleen, right? We mentioned that the spleen, when you have, it has that kind of really that red pulp. There's a lot of like that trabecular meshwork that it has there that allows like for the red blood cells to kind of be pushed through it, and that's where you can have a lot of pathogen exposure there within the blood. So we have problems where we mentioned sickle cell patients, right? What's the problem with sickle cell patients? Yeah, their blood forms that weird conformation, that kind of sickle shape, where they're not really flexible anymore, and so they can actually get lodged into the spleen and basically cause there not really be a lot of blood flow there. So it's really kind of diminishing the ability for the spleen to process things like pathogens, and that makes them more at risk for having infections. So that's one of the big problems we run into with our sickle cell patients. Is we have sickle cell patients who come in with fever very frequently, and so essentially they have been made immunocompromised by this functional asplenia. So we have to give them lots of antibiotics, rule out infection, and then see what's going on with them. So they have a whole host of other problems, like pain crises, but the infection aspect can be another common reason for them coming to the ER. So we see a lot of those patients coming in. But again, other organs can filter lymph for pathogens as well. So that's where you'll start to see some of those lymph tissues being expressed there. Yeah, so places like the lymph nodes, the tonsils, things like that, they're going to be filtering the pathogens that are coming through the lymph tissue. Yep. So you can see how a lot of the lymphatic capillaries are going to have a very close approximation to the blood capillaries. They should be able to transmit these white blood cells back and forth pretty easily for the most part. So if it's sensing, hey, we have bacteria here, we need to send out white blood cells to this site of infection, they can get into the bloodstream fairly easily for the most part. Here's another good picture. We can kind of see a lymph node. You can see where these afferent lymphatics are going to be sending in lymph tissue into the body, and then you can end up having these afferent lymphatics where things can then be circulated back out to the bloodstream eventually, right? So all this, basically you have a lot of T cells that are located within here, some B cells, and basically when you get presented with those pathogens, you can then respond to them appropriately, right? So again, when people get an infection, what can sometimes get swollen? Their lymph nodes, right? Because that's the body responding to that. Essentially, it's starting to basically kind of ramp up activity to try to be able to respond to that. And so sometimes you can see swelling of the lymph nodes there. Notice you're going to have lymph flow throughout the entire body. One of the things we run into sometimes with, again, when you think about like an infection, like kind of like the TV thing is always like you see a red line moving up the arm or whatever, and then if it gets to the heart, then you're dead, right? That's basically is that local inflammatory reaction to that lymphatic flow that you're seeing there. It's causing a lot of vasodilation. That's why you see that redness there. And then they say, well, if it gets to the heart, then it's, now all of a sudden you have septicemia essentially. So that's what they're trying to get at, even though it's probably not a very accurate representation of that principle. Okay. All right, so I'll give you guys a 10-minute break now. We'll come back and continue on. Keep going. Just a few points of clarification. So when talking about end-diastolic volume in response to exercise, the chart on there says it stays unchanged. That's not to say that it never changes, right? So for instance, there's always going to be a period of adaptation to where, say, for instance, you were lying down on the ground and then I stood up immediately. You can end up seeing drops in venous return, right? But for instance, if I were to say lay down, but then I lift my legs up, what would that do? Should increase venous return to the heart, right? That immediately would cause the increase in the end-diastolic volume because that's just more blood coming back to the ventricles. But then what would the ventricles do in order to compensate for that? It would increase stroke volume, right, immediately, and then the sympathetic nervous system can come in to activate, and then that would do what? The sympathetic nervous system. Yeah, that would actually increase heart rate. So immediately you can see an increase in end-diastolic volume, which will cause that Frank Starling method, or that mechanism to increase stroke volume. That would increase cardiac output. But say like you start running, that sympathetic nervous system will then increase your contractility, which will diminish your systolic volume. It will also increase the heart rate. So that's how your body is trying to respond to that increase in diastolic volume, is by trying to beat harder and faster, essentially. Okay, so there's always going to be a period of adaptation where you have to adjust to that. Older patients, they unfortunately end up having a slower ability to respond to that, and that's where you can have issues where they end up falling or exercising intolerance, things like that. Does that make sense? Everyone with me? Okay. The other thing is the B memory cells, just to clarify, those are the ones that have a lot longer half-lives than just the B lymphocytes themselves. So once they get differentiated into a memory cell, those are the ones that potentially could have lifetime applications. Okay. So just to differentiate there. Thank you for those corrections. All right, moving forward. Are any other questions before I go on? All right, so going forth with local inflammation, so this is going to occur, you can see this primarily when you have things like breaking the skin, you have local inflammation that can happen here, and so this is kind of the process that occurs. Again, you're going to find that things like macrophages and the mast cells, they are typically going to be releasing these cytokines and chemokines that help to attract those neutrophils. So again, whenever you have areas of skin or really any kind of tissue whatsoever, they're really not that far off from a capillary. So I think like the average is like no more than 50 micrometers off from a capillary. They can release these chemokines, these kind of degranulate essentially. They can release cytokines into the bloodstream, and that will then signal the immune system to come and respond. I mentioned the first cells that usually show up are going to be what? Yeah, probably the neutrophils are going to be the first things that are there. You can also see that the complement proteins, we'll look at some of those in a few minutes, they will start to get activated, and they can also attract some of these cells as well. Neutrophils are going to then attract more monocytes to come, and they can differentiate into macrophages. And then finally, the T lymphocytes are generally the last ones to the party. They show up fashionably late, but they're still very important for causing that inflammation to be dealt with. Right. So you can kind of see this wound happening here, foreign particles or bacteria, whatever it happens to be. Notice you're going to have the things like the clotting cascade may start to activate around this area, but these kind of mast cells and macrophages that were already there in the tissue to begin with, they're just kind of hanging out there waiting for some action. They're going to start to release those chemokines and cytokines that can help to attract the rest of those the immune system there. Then you're going to have this process where the neutrophils show up. You guys know what this is called when the cells kind of cross that membrane? diapedesis is what that's referred to. So you have diapedesis of these neutrophils into the tissue. And notice, like, also when you're releasing these cytokines, we mentioned that a lot of things like histamine and whatnot, they cause vasodilation or vasoconstriction. Vasodilation. Histamine is going to drop your blood pressure because it causes vasodilation, which is a good thing in this point because it actually makes these capillary walls more leaky. It allows for both fluid to come through and also these cells by opening up those kind of those junctions between the endothelial cells. Makes it easier for those cells to cross over. So when that occurs, that's why you see tissue swelling that can occur when you have an area of injury, because again you're having more edema, more blood flow to the area. That tissue is going to, that fluid is going to kind of partition out of the bloodstream into that area. So that's where you get the swollenness that comes from that. Also, is where you get a lot of heat because you're causing vasodilation, so that's drawing more of that kind of that warm blood to the site of the area of injury. Okay. Oftentimes there is competing issues going on, right? So you can have an issue, or if I was breaking the skin and there was some bleeding going on, you may try to cause some vasoconstriction to limit blood flow to certain areas, but when you have these cytokines being released there, they can have some antagonistic effects, right? So again, when you cut yourself, you're not immediately stop bleeding, but there's going to be some inflammation that happens there. You're going to see a little bit of swelling around that area. You're going to see some inflammation that happens there due to the effect of histamine and things like serotonin affecting all of that. So sometimes they can be kind of at odds with one another, and sometimes it depends on specifically the area where it's kind of being affected. Yes, ma'am. Yeah, so things like the mast cells and the macrophages, they can release vesicles that have some of these cytokines and chemokines in them that will get eventually partitioned over into the bloodstream and then attract those other cells. For if you had localized like granulocytes, they can release basically you only see the granules because they stain. The way they stain on those slides and whatnot. So you can still have vesicles that contain these chemicals. They may not be called like granules necessarily. They may not have that appearance, but they can then be basically have exocytosis, get out of the cell, and then cause an attraction. I don't know. I have to look that up. I don't know. Maybe you have someone who's like someone who knows a lot more about the specific white blood cells. But all I know is they release the chemokines and cytokines, and they attract other white blood cells. That's as far as you need to know, at least for our purposes for this test, and also probably most really for clinical medicine, I'd say, unless you go into immunology specifically. I don't know if you guys have any interest in that, but that could be one route. Anywho. Okay, I already see my reviews now. He doesn't know anything what he's talking about, but problems. I watched a YouTube video on it and everything. Just kidding. Okay, so anyway, so looking at the actual inflammatory reaction here. So again, if you have an inflamed site by these leukocytes, you can see the intensity, kind of how these different cells are going to cause different intensities, and also the different time frames. So again, looking at over the course of hours, you can see the neutrophils are going to be responding fairly quickly to the site of inflammation. Monocytes are then going to be responding next. They're not really going to have as high of a degree of inflammatory effect as the neutrophils will, and then finally the T cells are going to show up last. Pretty, more sustained, kind of high intensity kind of inflammation that happens there. Okay. So looking at things like activated macrophages here in the tissue, they're going to start to release a number of these different chemokines and cytokines, as I mentioned. This is going to be called chemotaxis when it's causing attraction of other white blood cells to the area of inflammation, right? So these are things like tumor necrosis factor. You have things like interleukin-1 that gets released here. And you can also have some of these colony stimulating factors. This is what CSF stands for. Basically, you can have granulocyte macrophage colony stimulating factor, and then just individual granulocyte colony stimulating factor and macrophage colony stimulating factor. What do you think these do? So the colony stimulating factors, they do a little bit of attraction, but one of the main things they can do is actually stimulate the bone marrow to start to produce some more of these inflammatory cells, right? That's why you can see that when you have an immediate infection, like you don't necessarily see changes in the CBC immediately. Sometimes it can take time for those effects to occur. This is also where if we have patients who, for instance, they have leukemia, and we treat them with chemotherapy and it kills off a ton of their white blood cells, what we can actually do to try to help stimulate them to grow those back is we will actually give them recombinant granulocyte macrophage colony stimulating factor, and that will stimulate the bone marrow they have to start to replenish the cells that we've just killed off, right? So we can actually give these as help to increase the number being formed of those white blood cells, and things like tumor necrosis factor and IL-1 are going to be more important for the actual chemotaxis and drawing more of those cells to the area, right? So they can have kind of a dual purpose. attracting more cells and also stimulating formation of new cells. So you can also see, again, sometimes these can come from the endothelial cells themselves, or like fibroblasts or lymphocytes in the tissue. Again, very similar kind of factors that are being involved here. So tumor necrosis factor, interleukin-1 are also some very important ones that we'll be looking at, especially when we look at like certain medications for treating chemo next year. So again, the mast cells, they're going to degranulate, which is just kind of the general term for releasing those vesicles of those inflammatory cytokines. They can secrete things like heparin. So heparin does what for us? Yeah, it's kind of a natural anticoagulant. So in some cases, you don't necessarily want to wall off these capillaries. You don't necessarily want to lead there to be clots that form there. So sometimes they're giving heparin that allows for more free blood flow, to allow for more of that tissue edema to occur, allow for those cells to come in. So heparin can be released in some small amounts. You guys remember the enzyme that heparin works with? Antithrombin 3 is a big one, right? This helps to inactivate some of those clotting factors. Histamine, we mentioned, is going to be vasodilatory and cause these gaps here to be a little bit bigger to allow for things like neutrophils to cross over. Prostaglandins, which we mentioned happen through that arachidonic acid pathway. These are also going to be useful. We mentioned some of the prostaglandins can cause vasodilation as well. Some of them are going to cause vasoconstriction, so it'll be a little different, but in general, they're going to be pro-inflammatory. And then you also have things like leukotrienes, which leukotrienes are going to be kind of on the other side of that arachidonic acid pathway. You can either have them go to be prostaglandins or leukotrienes. Leukotrienes become more important when you're looking at inflammation in the lungs and looking at asthma. That comes up there quite a bit. And so, again, all in general, what you're going to see is you're going to produce this warmth, swelling, and pain that can occur here. Some of these chemicals, things like the prostaglandins, they can sensitize the pain fibers, so they're more sensitive. They're going to be firing off more action potential. So you feel, hey, I've got an injury here. I've got some sort of something bad's going on. I need to take care of it now, right? Again, they're also going to be recruiting more leukocytes to the area of inflammation. That's where you kind of see this positive feedback loop to try to get as many cells to the site to deal with that inflammation there. All right, so the neutrophils, they're going to be mainly killing organisms through phagocytosis, so they can they're not going to be as effective as the macrophages are as far as number of bacteria they can inactivate. But the nice thing is they're going to be able to release these neutrophil extracellular traps, basically to grab the pathogens, engulf them, and then inactivate them. What you end up finding is, when pus develops in a wound or something like that, a lot of times that's going to be a lot of kind of dead white blood cells, a lot of dead cells. After they have kind of engulfed all these pathogens, they will cause this they'll autolyze, essentially, where they'll kind of cause apoptosis. They'll break themselves down, and that usually ends up getting walled off by some amount of granulation, where they can then be reabsorbed back into the lymph tissue, or you can expel it if you have like a little whitehead. You can pop that. Just kidding. Sorry. Anywho, but they're also going to be releasing some granule proteins that draw monocytes to the area as well. Okay. The monocytes are going to be kind of the second guys to show up to the party. Monocytes then get differentiated into macrophages, and then as the inflammation progresses, you can start to see some of the B lymphocytes producing antibodies against those bacterial antigens as well. So you start to see the lymphocytes kind of playing a role here. So for instance, if you were to have, say, something like a macrophage or something start to, say, engulf a bacteria, it will start to break down that bacteria, and then able, in some cases, to present some of those antigens onto the cell surface, which can then interact with some of the antibodies on the B cell surface there. And then once that gets internalized, it can eventually lead to formation of things like the plasma cells, which again is going to be responsible for neutralizing all these bacteria or viruses or whatever happens to be. We'll notice here how they have a T helper cell. We'll talk about that in a little bit, but that's also going to be super important for helping the B cells to differentiate those plasma cells. So just looking at some of the symptoms of inflammation, you kind of see this redness and warmth that occurs here. Again, a lot of that is due to histamine causing that vasodilation, just more fluid, more blood getting to the area. You're going to start to see pain. A lot of that's going to be releasing due to the release of prostaglandin E2. It's going to be really important for sensitizing those fibers. And again, why we like to use things like NSAIDs to treat pain, because that actually helps to prevent production of those prostaglandins to help reduce that pain that you're sensing through those fibers there, right? And I mentioned the pus ends up developing from that phagocytosis. Usually the neutrophils, macrophages as well can be involved with that. Once they kind of get broken down, they can then be reabsorbed in the lymph tissue. Here's someone with a very swollen knee. Sometimes you see this with certain patients with autoimmune conditions. So they had like juvenile rheumatoid arthritis. We see that quite a bit from our patients. They get very, very swollen joints that usually has to have basically trying to think of the word. Basically, you have to end up drawing out a lot of the fluid off of the joint in order to release some of that pressure that's there. That can be a very bad sign of inflammation. Another sign here. I'm sure all of you guys have experienced inflammation. You kind of know what it feels like. Not good. Okay, so looking at the local inflammation, you can kind of compare and contrast the innate versus the adaptive immunity that's occurring here. With the innate immunity, once the bacteria is going to enter into a break in the skin, that's where you can have kind of resident phagocytic cells. So some of those things like the macrophages kind of just live out the tissue normally. They're going to start to engulf those bacteria. Neutrophils are also going to be the first ones to kind of cross over from the bloodstream into the local site of inflammation. And then you can also have this kind of non-specific activation of complement, right? So again, these are all things that you can do just at baseline. Don't have no need to have a learned response to that. Then you can have the adaptive immunity here where the B cells get stimulated. They're going to produce specific antibodies, which can then respond to those pathogens. This will help to increase phagocytosis by some of these cells. So again, once you have the antibodies kind of bind there, sometimes that can trigger off other cells to increase phagocytosis. Sometimes the antigens, the antibodies themselves will cause the bacteria to also be kind of neutralized essentially by kind of binding up some of those active sites. Have you guys heard of this term opsonization? What is that? Yeah, I think it makes the bacteria more tasty is what I think about. So it makes it easier for those cells to come along and then phagocytize that, right? Again, you're going to have extravasation of the diapedesis that allows new other leukocytes to involve the area. I think there's a lot of times this is through a lot of the interleukins and things that get released from some of the things like the T lymphocytes that happen there. But again, you're going to have this vasodilation, increased permeability there, a lot of it due to the histamine, and that produces that redness and edema, right? So that's kind of non-specific, but basically you can see where the adaptive areas are going to be at and where the kind of the the innate immunity is kind of involved and where the adaptive immunity gets involved as well. Kind of working together, you need both, otherwise you can end up having immunosuppression. Okay, so looking at more functions of the B lymphocytes. So again, looking at actual exposure, so for instance, if you had an invading microbe here, notice these little particles on the end of them. Those are usually the epitopes or the things that we like to have a reaction against. A lot of times macrophages will end up kind of engulfing these, and they can present them out onto these cell surface receptors essentially. Things like T helper cells can respond to that. They can say, hey, we have this antigen being expressed here. And that can also help to kind of downstream lead to these B cells being activated into plasma cells. The B cells themselves can respond to this as well. So once they end up having their antibody being hit by that, so just think about it like any other receptor, it's able to internalize that and eventually can have a processed antigen and eventually will lead to production of these plasma cells, which have a ton of antibodies in them. And then some of them will also be those memory cells, which we mentioned are kind of the long-lasting immunity that we'll have with the B lymphocytes. So again, notice the T helper cells are very, very useful here. If you lack your T helper cells, and you guys know any conditions where you might lose those T helper cells? Yeah, HIV is going to be a big place where you lose a lot of those. If you don't have that, it's very, very difficult for you to initiate a lot of these immune reactions, and thus you're much, much more likely to have infections that can occur, right? Even to things that like me and you are exposed to every single day. We have a good, competent immune system. We don't get things like PCP pneumonia. These patients are not able to have a good response to that because they lack these T helper cells, right? Okay. Again, just another picture kind of showing you the same thing, how, again, plasma cells are going to be the kind of the business end of the B lymphocytes. They're the ones that are doing most of the neutralization of the pathogen versus the memory cells, which are going to be useful for that learned immunity for a later challenge down the road. It also called these clones that occur here. So again, when they have this activation, it's starting that mitosis process. So these are all going to be clones of the same cells until they differentiate into their plasma memory cells. Okay, so looking at the primary versus secondary response, this is why we like to do vaccines sometimes in multiple doses. This is why sometimes you'll see a more dramatic response to an infection the second time around because of this difference between the response with the B cells versus the memory cells. So again, the first antigen gets injected here. Notice over time, you're going to notice that primary response. This is where those initial B lymphocytes get activated, and they're going to start that mitosis process to form clones. Eventually, you're going to notice that they'll make some of the plasma cells to deal with that initial antigen, and then they'll have the memory cells left over. Once you have a second antigen exposure, this is where we're going to see those memory cells all start to produce more plasma cells. You get a much, much greater response here, and in some cases, immunity from that pathogen. Okay. So what about the antibodies? What are the antibodies they're actually releasing? They're also known as immunoglobulins, and so we have 5 classes of them. We're primarily going to talk about IgG, IgA, IgM, and IgE. IgD is kind of one of those ones we don't have a ton of clear understanding about what its main role is, but the other 4 are the primary ones we're going to talk about here. Basically, IgA is really important because this is one of the ones that are secreted in both saliva and also mother's breast milk. So when infants are born, how good is their immune system? Yeah, so they have kind of a poor innate immune system themselves because they have very thin skin. They may not have their GI tract really producing a lot of acids. They can have some issues there. But by giving the patient this kind of passive immunity, we'll talk passive versus active immunity, by giving it through the mother's breast milk, giving them lots of these IgA, they can have basically the mom's immunity for a short period of time until they're able to kind of form their own antibodies and get those new challenges. So, yes, ma'am. Yeah, so that is a concern, is that they're not really getting all those antibodies from mom, so they may have an issue where they are not going to be able to have a response, right? So there may be a risk of them getting sick. This is also why there's certain vaccines we cannot give until the patient is at least 12 months old, because of the fact that's basically how long the IgA will stick around for in the infant. Because if mom has had, I think it's the MMR is the main one, but MMR was measles, mumps, and rubella. If the mom's been vaccinated against that, she has his IgA made against that. If you were to give it to the baby, they would basically just wipe it out because the mom's IgA would sit there and would neutralize it. Versus once they are old enough, they've kind of processed mom's antibodies away, they can start to produce their own now. So that's why you wait till 12 months for certain vaccines to be given. So that's going to be one reason. IgE is going to be really important when we talk about allergic symptoms and hypersensitivities like anaphylaxis. We'll talk about that there. IgM is going to be one of the primary antigen receptors on lymphocytes prior to immunization. Cells B lymphocytes will be expressing IgM on the cell surface, and they can be secreted to some degree in primary response. And then IgG is going to be kind of one of our main antibodies here, where we're forming one of the main ones in circulation, gets produced in increased amounts after immunization, and definitely during the secondary responses. That's kind of the primary immune globulin we're actually sending out. So there are some cases where patients may not actually be able to produce their own antibodies. In some cases, that is kind of primary inability to do so. And so in some cases, we'll give them exogenous IgG in some cases. So if you're ever in a hospital and someone's getting IgG, that's basically what we're doing. It's giving them kind of donated plasma from other people. They've spun down, got all their IgG against all their different pathogens they happen to be have some immunity against, and then inject it into this other person to try to give them some short-lived immunity there. So that could be one thing you might see occasionally. Okay, so again, table kind of discussing some of the main functions there. So again, IgG is mainly involved in the secondary responses after immunization against a specific target. IgA is going to be the main one in saliva and also in mother's breast milk. IgE is the main thing responsible for these allergic symptoms, which we'll cover a little bit later. IgM going to be for those primary responses before immunization has occurred, and then IgD, again, we don't know a ton of other functions, but probably has something to do with lymphocyte immunization over time. Okay, so how does this process occur? Again, we mentioned things like, if you have bacteria being absorbed through the GI tract, they get into they get somewhat digested by some of these macrophages and things like that. So you can have these processor areas or processor cells, which will be able to present basically some of these antigens out to our cells. So basically, the process antigen can then be released. We have these major histocompatibility complexes here that will also be important in responding to some of these antigen-specific receptors. These are important for some of these antigen-presenting cells. Will express that as well. Here you notice we have a T helper cell, which releases a lot of these lymphokines. We'll talk about these more in detail, but these are a lot of interleukins and things like that. And basically what you can see is that it'll have some inhibitory or usually excitatory effects on the cytotoxic T cells and the suppressor T cells. But the big thing that the T helper cells also do is going to help with the B cells and help them to differentiate into plasma cells. A lot is going to be, once they bind to this antigen, they can notice the antigen binding here as well on the B cell. That's what's going to stimulate that production into the plasma cells. And then they can release all the different immune globulins there to different degrees. Again, IgM probably being one of the primary ones during that initial response. IgG going to be after the memory cells get activated and turn into plasma cells. they're pretty much necessary. So like I mentioned with like HIV or a patient with AIDS, essentially if you wipe out all their T helper cells, they're not able to really mount very good immune responses to anything. So those patients generally, you're going to get some response, like the B cells can still activate without having those T helper cells, but it's to a much diminished degree. So they're pretty much necessary. Otherwise, the patient is very immunocompromised and very likely to die from infection, right? Because like no one actually dies from the HIV virus itself killing them. It's usually the secondary infections they get because all their T helper cells have been wiped out, right? Okay. The other thing that's really important, this is part of our innate immunity, is going to be this complement system, but it's going to be integral to helping with activation of some of our adaptive immunity. Basically, the complement system, there's going to be several different proteins here. It's important to know which ones are kind of involved in different processes here, but basically, you notice that's kind of a similar cascade to what we see with the clotting cascade, where one kind of begets activation of another. Big things to note is that the C1 is going to be the main thing that gets activated kind of early on when you have an antigen-antibody complex here. So basically, if like a B cell has released an antibody, binds up an antigen, that can activate the C1 here. Okay, and that can kind of kick off the cascade. Big things to note, C2, 3, and 4 kind of help to serve as activators. So they can also be sent out and can help to activate mast cells and these basophils. So those are really good to help with kind of enhancing the inflammatory process. You'll find that C5 through 9 are going to be really important for helping to attach to the cell membrane and can actually destroy it. So it's kind of the leading to direct cell lysis that can occur there. Other things to know is like complement 3 leads to opsonization of the bacteria. So again, it kind of coats it and allows it to be a little bit more tasty to the macrophages. They can then chew them up and then break them down. We'll go into more detail on these in just a minute. So there's a couple of different pathways here. We mentioned that kind of classical pathway, usually going to be responding to things like those immune complexes, or if you have like apoptotic cells or cells that are initiating cell death, they can have the complement system activated through this pathway. Sometimes you can respond, the complement system can respond to things like lectin or certain bacterial carbohydrates. So if you think about certain bacteria can have these carbohydrates that get released, that can activate the complement system and initiate an inflammatory response. And then sometimes you have kind of these alternative things here. So think about like foreign surfaces. So if you had like certain plastics or metals or something within the body, it can cause a response there. Damaged tissue, bacteria can also cause this pathway. And again, we're not going to get super in depth onto that, but mainly we're going to talk about this kind of classical and terminal pathway. And again, C5 through 9 being really responsible for causing that cell lysis for some of those pathogens. So you can kind of see here how, say we have like a bacterial surface, again, they would have the bacteria expressing an antigen on its cell surface. The antibody would come down and bind this, and then that can activate C1 here. So you get that complement being activated. And eventually, further complement proteins are going to be activated in this cascade. And eventually, when you have that 5 through 9, it's going to end up binding and opening up that cell wall to allow for a lysis of the cell itself. A little bit different pathway here. As you notice, for instance, if a bacteria, we're going to that lectin pathway. If you had a certain carbohydrate being exposed on the surface of a cell, you could basically have the same complement system being activated through binding of that. So still a bit different pathway and different way to kick off that response to different initiators. Okay. So again, this is part of a non-specific pathway. So again, we all have the complement system kind of active at birth, and so again, it's going to be triggered by binding, typically of antibodies to antigens. It's kind of the classic pathway, and also the alternative pathway is going to be through some of those bacterial membranes, carbohydrates they'll express on their cell surface. Now, in some cases, you'll find that antibodies binding to the antigens does not itself actually destroy the bacteria. In some cases, if you have enough of them binding up, sometimes they can actually form holes in the bacteria. Sometimes they can cause this agglutination where of antibody binding to the antigen, you get enough of those kind of clumped together to inactivate the bacteria. But in this case, when you're activating the complement system, the binding of antigen to antibody is not really inactivating the bacteria in those cases. But it does label the targets for attack by those phagocytic cells. So again, it makes it, that opsonization makes it more likely for macrophages or neutrophils to come along and engulf those cells. So I mentioned they're going to be designated as C1 through 9. C1 is going to be that major recognition protein that gets activated with that antibody-antigen complex. 2, 3, and 4 serve as activators that can help to activate those basophils and other mast cells. And then 5 through 9 work on that cell membrane to destroy it. Okay, so the complement-dependent cytotoxicity, this is going to be a pretty rapid and efficient process when activating here. So again, it involves antibodies bind to the antigens to destroy the cells. You'll see that the IgG and IgM, we mentioned IgM being more seen in that kind of primary response, IgG more in the secondary responses. Those bind to the antibodies, to the antigens, are going to activate C1 there. And then C4 ends up binding to the cell membrane and then becomes more active. So you can kind of see down here, you end up seeing C1 getting activated, followed by C4 when it attracts to that cell membrane. And then once you finally get down to, say, C5 through 9, those are going to be inserted into the actual bacterial cell membrane. It's going to create that large pore, and we have that opening up there that can eventually cause basically efflux of all those contents out of the cell and cause that lysis to occur there. Sometimes just the influx of, it just depends on kind of the tissue that it's in, if it's going to cause influx or efflux. Lots of different things are going on there, but essentially, if I put a big hole in you, you'd probably die, right? Same thing happens to bacteria, essentially. So, not that I would ever do that. Okay, so diving a little bit further into the function of the T lymphocytes. So I mentioned that we have our killer T lymphocytes. We're talking about these CD receptors. These are basically co-receptors that are involved in helping us to recognize some of these cells that we need to target for destruction or to target for some sort of activation. So you notice there are suppressor T cells, or these killer T cells, are also going to be called CD8 cells. And so these are going to be useful for helping to destroy cells that are either infected with like a virus or a fungus, or if you have like a malignancy or some sort of cancerous cell that we are able to differentiate, and we say, hey, this looks like a cancerous cell. And it'll be based on generally the type of whatever's on the cell surface of whatever we're kind of responding to. So you notice the CD8 cell, again, is going to be a learned immunity. It's going to be something that we're going to have a target for on the cell surface here. Again, as it binds to whatever its target happens to be, that's where it can end up having lead to eventually to cell lysis, essentially. So able to break down the cell. These can then be absorbed back into the lymph tissue, or it can be formed into pus, whatever happens to be during that time. But because it is cell-mediated, it means that the cells are actually having to touch contact to contact, right? So again, we saw like the humoral immunity. You can have B cells just release antibodies out, and they can be active kind of wherever they go. Versus here, the T cells actually have to be in contact with one another to allow for that cell-mediated immunity to occur. That's kind of where those names come from. So the helper T cells, these are also going to be known as CD4. So if you ever hear of someone getting a CD4 count, essentially what they're looking for is going to be these T helper cells, because they express the CD4 receptor on their cell surface. And so again, they're critical in that cell-mediated immunity because they help to improve the ability for those B lymphocytes to turn into plasma cells. So without that, a lot of them don't get turned into plasma cells. You don't have that same kind of immune response. And they also work to enhance the ability for those CD8 cells to kill targets as well. So they're very useful, very helpful, as their name implies, to helping both B lymphocytes and also those CD8 cells. So here you can notice, basically here, if you were to see your antigens here being expressed, the T helper cells would have this kind of CD4 co-receptor that ends up getting activated along with just that T cell receptor itself. Binding of both of these is what kind of helps to activate it and lead to activation of both the B lymphocytes and also those cytotoxic T cells as well. And again, because the HIV is able to target this cell in particular, due to some of the surface proteins, they will end up causing eventual destruction of those cells and leading you to not really be able to activate either of these pathways quite as efficiently and lead to infection eventually. It's one of those things where, based on how frequently or how often those viruses are replicated, we can actually monitor the CD4 count and see how well the patient is doing. So you can monitor it over time, and if a patient, say had HIV, did not get treatment, you eventually see the gradual lowering of the CD4 count to eventually be negative or be zero, and so that patient would be very, very susceptible to infection. That's one of the main things we look at when we're treating those patients with antivirals, is to make sure they're recovering their CD4 count as best they can. So we'll talk much more about that later on in Pharm. So you can notice here's a T helper cell on the left, here's a T killer cell on the right, and there's these CD4 co-receptor here that helps to basically the molecule that's responding to the foreign antigen. They have that normal T cell receptor that also gets activated along with that CD4 co-receptor. For the T killer cells, CD8 is the co-receptor there, and that will initiate the killing process in this case. Okay, so again, looking at the interaction between antigen-presenting cells. So again, if you had like a macrophage that was able to ingest some of these foreign particles, it's able to send it out and put it onto the surface of itself, along with this basically these major histocompatibility complex molecules. Essentially, you're going to notice this protein gets sent out to the cell surface. It has the antigen kind of on the end of it, and allows for binding of both the T receptor and also the CD4 receptor for these T cells. And again, once that happens, that gets activated, then it can go along and help to activate these B cells, eventually lead to plasma bodies being formed there. Does that kind of make sense? So again, so usually the T helper cells, they're going to be responding to these antigen presenting cells versus like the T killer cells, they're going to be responding to the actual bacteria or whatever the cells that it needs to kill essentially. Okay. But again, both of them are going to be cell contact mediated, so that's why they're both considered to be cell mediated immunity. Just another picture kind of showing the same thing where, again, the T lymphocytes, the helper cells are going to be having a positive effect on B lymphocytes. The T killer cells, sometimes they'll actually be releasing some regulatory molecules that may actually inhibit this process. Say, for instance, once the infection has been dealt with, you probably don't need to produce a lot more plasma bodies at that point. You can have some kind of negative feedback loop kind of effects there. But notice T helper cells are also useful for increasing activity for these T killer lymphocytes as well. And so looking at the lymphokines that get released by the T helper cells, so big things to note here, things like interleukin-1, these help with proliferation and activation of other T lymphocytes. So you can help to stimulate further production of T lymphocytes in some cases. IL-2 is going to do the same thing. You see, IL-3 is going to be more important for proliferation of the actual bone marrow stem cells. So it's kind of working at a higher step in the pathway to produce more lymphocytes eventually, but it can lead to both B and T lymphocytes being made at that point. IL-4 is going to be important for promoting production of IgE. And we said IgE is important for as a mediator for those allergic reactions or anaphylactic reactions, so that'll be important there. IL-5 is going to be necessary for activating those killer T cells or the CD8 cells we mentioned. And then you'll notice IL-6 is proliferation and activation of both T and B lymphocytes. So just in general, it's going to be helping to stimulate and further increase that inflammatory reaction to allow for better pathogen killing or pathogen neutralization essentially. Here's just another table. We can kind of see some additional details on there. Again, IL-6, IL-1 through 6 are going to be primarily released through those T helper cells to eventually kind of enhance that inflammatory reaction. Yes, ma'am. Yeah, in general, those are going to be some of the big things that the T helper cells are releasing are a lot of these lymphokines. Yep. Because once they get active, so because usually the macrophage may be the first thing that will present those antigens, and it says, okay, here it is on the cell surface. T helper cell can bind to that and it says, okay, we definitely have an antigen here. We need to deal with this. Let's go ahead and release these lymphokines to help both attract, increase the differentiation of those cells, and increase the actual production of new cells. And again, you notice that granulocyte monocyte stimulating factor. Again, that's going to be useful for helping to increase production back in the bone marrow. Okay, so moving on, we talked about cell-mediated immunity, talked about innate immunity. Now we're talking about active versus passive immunity. So what do you guys think the difference between active and passive is? So active immunity would be the thing that we're making our own immunity against a pathogen, right? So we even made our own ability to fight the flu or to fight pneumococcus or whatever it happens to be. Versus passive immunity is that we are getting the ability from someone else or something else to fight whatever infection it happens to be. Okay, so we'll look at some of the differences there. So again, active immunity, again, the primary response, again, this is where we see things like, the B lymphocytes being activated by that primary response and eventually those memory cells with the secondary response here. This is active immunity where we've kind of gained our own immunity against some sort of pathogen or some sort of stimulus. Again, active infection takes about 5 to 10 days before those antibodies can actually be detected in the blood. So it's not super quick that this occurs, but the person's going to get sick. So this is like getting the chicken pox when you're a kid. Anyone get chicken pox as a kid? All right, so I don't know if anyone's mom made them hang out with someone else that had chickenpox to get it, but essentially they were trying to initiate some very active immunity in that case. But basically you get sick that first time. Then for the secondary response, you're going to have later exposure to the same infection, same whatever antigens it happens to be, but you should have maximum antibody production in less time, so you're able to respond much more quickly, and then hopefully don't get sick at that point. Okay, so it's active immunity. You're actually producing yourself. So again, development of that secondary response is what leads to active immunity. Again, it's going to require prior exposure to the antigen, and helps to protect against future exposures as well. So for instance, this is where a lot of our vaccine theory comes from, is that if we give you an initial exposure to something, we can then help you protect you from actual exposure to it later on. So there's some different things we can do there to help make sure that you don't actually get the infection that we are trying to protect you against that first time. But active immunity also helps us to make vaccines, and the vaccines themselves include the antigen, but are really not going to be virulent. So I don't give you the flu. One of the things you always hear, though, is that someone gets the flu shot, and what do they say they get right after? Oh, I get the flu. You didn't actually get the flu. You probably have an immune reaction to the flu antigen that we injected into you. That's not actually the flu. The flu is a lot worse than what you're experiencing. But you'll hear that quite a bit. But essentially what you're seeing is that we're giving them versions of those antigens that are either have been inactivated, or they're made less virulent, or it's just a subunit of that antigen that the body can respond to, produce an immunity against it. And that way, when you're actually exposed to the real thing, whether it be measles or it be the whooping cough or tetanus, you can respond to that appropriately and neutralize that pathogen. Okay. So you get 3 ways to accomplish. I mentioned using a killed virus, where essentially you can take a virus and actually kill it, and you still have the whole virus there. Sometimes you can actually have broken down components of a virus or of whatever pathogen it happens to be, and give that to the patient. They can respond to those proteins, and then they can develop an immunity that way. It's not going to provide the best sort of durable response, but it's usually pretty good for the things that we can use killed viruses for. Sometimes we can use a live virus or an attenuated virus, which basically means we have engineered the virus to be less virulent. It's still going to be the same type of virus, but it just doesn't cause you to be sick. And so we can do that for things like the MMR. And basically, they don't actually get the infection, but they can go ahead and respond to it. They get a much more natural immune response to that, and usually ends up being a lot more durable in the long run. Durable just meaning that if I get exposed to it years and years and years down the road, I still have an immune response to that. Okay. And then sometimes we can actually use genetically engineered recombinant viruses that do not cause any actual disease, but we can still respond to it pretty well. So things like hepatitis B would be an example of that. Okay. So passive immunity is going to be the passing of antibodies from one individual to another. The person's not actually making anything of their own. So when we give that IgA from mother to infant, that would be an example of passive immunity. So the baby didn't actually produce any of those antibodies, but because it's able to absorb those fairly well, it does develop some sort of immunity against certain diseases. So you have that from mother to fetus, just within the actual during the gestation process. You can have it during from mother to child, especially when you have that first initial milk, that colostrum, so that really high fat milk that's coming out. There's a lot of IgA that's in there. And then we have artificial immunization or antidotes we can give in the form of things like crofab. So if you ever get bit by a poisonous snake of a particular variety, we can actually give you a antibody that has been taken from sheep. We have basically immunized them against certain snake venoms. We can give this to you. It'll bind up that venom and cause them to be not active anymore. So, and does that mean that, can you get bitten by a snake a second time and be immune to it? No, because you didn't actually generate any of your own antibodies to it. Now, if people try to generate their own immunity against snake bites, yes, they're not very smart. They usually do not do too well. So I've seen that a few times. It's not good. Don't try to get immune to snake venom. It's not smart. Anyway. Who's new to Florida? Okay. We have a lot of poisonous snakes here, so just be FYI. Do you guys know what the poisonous snakes are? Coral snake? Yeah, so Florida is home of the coral snake. So if you ever see, you guys remember the thing to watch out for color-wise? Red on yellow, kill a fellow. Red on black, venom lack. Okay? So I just say red on yellow, run the hell away. Red on black, run the hell away. Okay? Don't mess with snakes. Okay? So we got coral snakes. What else we got? Water moccasins. Yep, we have water moccasins. What else? Eastern diamondbacks. Yep. What else? Those have pygmy rattlesnakes, and occasionally have copperheads. So those are the main poisonous snakes you'll run into in Florida. Just watch out. They're out there in the summertime. We'll even have bites even up through November, December in some cases. But right now it's prime time for them because it's nice and warm out. They like to be more active. So and crofab is very, very expensive, so we like to not have to use this unless we really need to. So. Nope, you can use it as many times. We've had patients I've treated at least half a dozen times because it'll still neutralize the venom that's being injected. Because the body's not producing any antibodies against the crofab. I've never had anyone actually develop that. So
They do against the horse.
they can have an anaphylactic reaction. So guys, shh. So one of the problems you can have whenever you're injecting kind of foreign antibodies into the patient is sometimes they can respond to that. So it's interesting, and it's kind of off topic, but for the coral snake antivenom, we actually use the full horse antibody, right? It's a big protein, very likely to have a reaction to it. So you can have a lot of people that will anaphylaxis when they get that. They get hypotensive, the throat starts to swell, it's real bad. The CroFab, though, this is actually just an FAB portion of the antibodies. We actually cleaved off part of the FC portion of it to make it a little bit shorter, less antigenic. So we actually have people have very rare they have any reactions to this. But just know, anytime you're injecting animal proteins into a person or someone else's proteins, they are likely to have, or there's a chance they can have a reaction to that. Yep. So. All right, so again, comparison to active versus passive immunities. Injection of a person with antigens is going to be active immunity because they can generate their own antibodies against that versus if we're injecting antibodies. If I were to give that person, give someone IgG, I mentioned, so we call it IVIG or IV immune globulin, would that be active or passive immunity? That'd be passive, right? Because I'm giving them someone else's donated antibodies in that case. That would be a passive immunity there. Again, the source of the antibodies for active immunity is the person themselves are generating it versus something else, whether it be artificial, could be the mother it's coming from, wherever it happens to be. And the method to get that is usually going to be either exposed to whatever pathogen it is, or we will give you an exposure to that pathogen, usually in some kind of attenuated or less virulent form, versus with the passive immunity, that's where we may be just giving you the antibodies ourselves via the IV, or like mother could could transfer to the child, either through the fetus or through the milk, whatever it happens to be. Look at the time to develop. Notice the time is very different here. So in some cases, you'll have active immunity in 5 to 14 days after being exposed to a particular pathogen, versus with passive immunity, the nice thing is going to be immediate. Basically, after the injection, they're going to be protected. So this is why sometimes if you have like an accidental needle stick, right? So say, for instance, you have a needle stick and you had no immunity against hepatitis B. Sometimes what we can actually do is give you, start you off on the vaccination against hepatitis, but we can also give you hepatitis immune globulin. Our immune globulin has already been made specifically against hepatitis B to neutralize any of the virus that may be circulating in your bloodstream as you develop immunity to the vaccine that we gave you. So I actually had a case of that where a mother did not want to vaccinate her child, basically was out at the park, got stuck with an insulin needle from who knows who, and at that point it's kind of like, well, we have no idea who that person is or what diseases they have. Let's go ahead and be safe and go ahead and vaccinate them and get them the IG on board. Sometimes we'll do that with rabies as well. Rabies has like an immune globulin that we'll give to provide passive immunity as we give them the vaccine to form that active immunity as well. Because why do we worry about rabies? Yeah, it goes to your brain. Is super fatal. Like if you actually develop rabies, like it's super bad. Like 2 people have ever like survived actually fulminant rabies. So that's why this is one of those things where we're like, okay, well, if we're not sure, if we think you may have an actual exposure, we'll give you the immune globulin for that passive immunity, and we'll give you the vaccine as well for the active immunity. So the duration of resistance, very long for active immunity, sometimes lifetime in some cases, versus very short for the passive immunity. As soon as the antibodies have been metabolized and gotten rid of, you're done from that standpoint. And then basically you want to use this, you want to use things like vaccines and exposures prior to the actual exposure to the real pathogens. That would be good if you can. That's why if you go to certain other countries, they'll recommend you get these certain vaccines before you go, so that way you can have immunity prior to then. But usually with the passive immunity, it's going to be after the exposure. So it's going to be, you've had an exposure, now we're going to give you the active immunity in a lot of cases. Okay, so I guess I'm going to go ahead and give you another 10-minute break here, and we'll come back and finish up this section and then move into the respiratory section. Questions on the last section, last hour. So we'll finish this up and then move into the respiratory physiology. I'll probably have to do another video. When's our review? Tomorrow? Holy Lord. Okay, I'll record that. I'll post it up. The review, we'll talk about a lot of that stuff, but you can go back and watch that again. Would that work for you guys, or would you rather just finish up the lecture material tomorrow? Yeah, I think you guys like the review too. So even if you don't know all the answers for the review at the time of it, you can at least go back and watch it, or at least learn some things along the way. So okay, so I'll do that. So I'll record the rest of the material tonight, and then I'll post that up. Probably try to do that today sometime. We'll see. We'll see. This is a long day. And then we'll do the review tomorrow, and then the test is Friday, right? Like farms on Thursday or something. So okay, got it. Alrighty. So anyway, so looking at tumor cells, we mentioned that we have some cells that will become cancerous that we'd like to get rid of. We're not always able to do that in some cases, but sometimes we can actually use antigens that can be utilized for blood tests. Sometimes we can utilize certain things that the body's producing, generate antibodies against them, and that way we can actually detect it in the blood, and that would sometimes be indicative of certain cancerous conditions. So a good example, this can sometimes be arise from changes in the actual proteins, because we know that when we have a cancer cells, there's obviously some sort of change in the genes that have allowed it to kind of replicate unchecked. So these mutations can sometimes be detected by searching for certain proteins, which can act as antigens, attach an antibody to it, and then be able to detect it. Other times, we have viral antigens from the virus that had actually caused the tumor in the first place. So like HPV or human papillomavirus is a very common cause for which cancer? Do you guys know? Yeah, cervical cancer is one of the big ones, right? So we're about cervical cancer, and that's why we recommend using like Gardasil, or there's now like a 9-valent form of that attacks a lot of different versions of the human papillomavirus. But you can actually look for viral antigens to see, hey, has this person been exposed to it? Do they actually have disease? But you see, normally you have overexpression of the antigens may trigger that immune response. So if the body is kind of detecting it as being something foreign or something it wants to get rid of, they can have activation there. So for instance, as far as like blood tests go, looking at something like BPH, or you guys know what that stands for? Benign prostatic hyperplasia, right? So that could be fine, all well and good. It could cause some issues for our male patients, but if they actually have a carcinoma in there as well, you can find some changes in that PSA, that prostate stimulating antigen. Basically, we can detect that, measure over the course of months to see, are we having an actual progression of disease or not? And that would be something we can actually detect in the blood and see, okay, do we need to go in here and do some sort of radiation, or what do we need to do in order to help this patient out? So that can be one thing we can do. You can sometimes see that we'll have different cells. This would be one of like your T suppressor cells, and also showing a CD8 co-receptor as well, can be responding to some of these tumor cells that are now presenting some of these different antigens or these kind of mutated proteins out to the cell surface that we can now have some responses to. So here you can have like an anti-tumor CD4 cell responding to this as well. Eventually, it can end up releasing those cytokines, and eventually tumor regression could occur. Probably doesn't happen as often as we would like, but it occurs kind of naturally in order to try to get rid of some of those cancerous cells. Hopefully we can trigger off apoptosis, as I like to say. I like apoptosis. I like that term better. Because it's like popping the cells, But anywho, so imagine if you were to look at some of these cancerous cells, you can see a T cell coming in and attaching to. Again, this is that cell-mediated immunity, because it's actually cell-to-cell contact. Now able to cause eventual cell lysis or cell destruction of those cancer cells. Okay, so looking at our natural killer cells, so again, how we can discriminate non-self versus ourselves. So I mentioned that the thymus is a really important space for the body to kind of vet the ability for the T cells to not target ourselves, right? So we want to make sure that if it's going to attack our own cells, we get rid of that T cell. It's not going to be any good for us. But we have these natural killer cells as well that are kind of related to the T lymphocytes, but they're actually part of that innate immunity. And so they don't recognize specific antigens, but there are certain things that will actually trigger them based on the receptors they're expressing. So in some cases, they can recognize some of these malignant cells or cells infected with the virus that they're expressing some sort of protein or carbohydrate that they can recognize, or they can be activated by some of these pro-inflammatory cytokines from things like dendritic cells in some cases. So try these natural killer cells, cytokines can be released from them, and they can also initiate some of the innate or adaptive immunity as well. So you can see things like interleukins being released here, other things that can also stimulate the immune system. All right, so looking at some of our immunotherapy for cancer, we can actually utilize try to direct our immune system to target some of these immune cells, or target these cancer cells, as I mentioned before. We can use things like therapeutic interferons. I mentioned we can use that for treating things like hepatitis, to try to treat those infections in some cases. Interleukins have also been used in some cases to try to help target specific cancer cells and spare some of our other cells, because you'll find that when we get to the chemotherapy section in pharm, is that a lot of our drugs are very good at killing cancer cells. They're also really good at killing all of our regular cells, right? We don't like that. We like to be able to specify and kill only cancer cells when we can. And so again, a lot of times they're not going to necessarily cure the cancer, but they can help to either help with progression of tumors. In the case of like viruses, sometimes they can help with suppress the viral replication. A lot of times these are not going to be curative functions though. just looking at the effects of aging and stress over time, you're going to find that susceptibility to cancer can obviously vary via several different things, not only your genetic makeup, but also environmental exposures. Things like cancer risk certainly is going to go with age. I think if everyone were to be immortal, they would eventually develop some sort of cancer at some point. It's just going to happen as you have genetic mutations that occur in your cells over time. I think sometimes cancer risk can also be related to some of these aging mutated lymphocytes. Also, you can have decreased thymus functions as well, which may make you not being able to have as good of cell-mediated immune competence, essentially. So essentially, as you get older, you may just get more immuno-incompetent as you go along. Also, especially under certain stress conditions, tumors are going to grow faster in those cases, and you can release more cortisone, which is also known to suppress the immune system. So patients are in a hyper-stress state. They're also more likely to get sick because of the fact that they are releasing all these corticosteroids. They're going to be depressing the immune system, and we're going to find that they're going to be more likely to have infections, sometimes possibly even cancer risk as well. So take a deep breath, just chill out. It's good for your health, right? Unless you're in PA school, then freak out. Okay. All right, so looking at some diseases caused by our immune system. So what happens when our immune system runs amok? We can have autoimmune diseases that can develop, and it's kind of alluded to this already. Basically, our immune cells can't really recognize or tolerate our self-antigens. You have things like autoreactive T lymphocytes and autoantibodies that are being produced that can cause inflammation and organ damage. This can affect tissues all over the body. We think about the joints a lot, affecting things like rheumatoid arthritis, but think about whole systemic disease states like lupus that can be a result of this. You can have autoimmune conditions against the thyroid, which can cause hyperthyroidism, all kinds of issues that can develop from this. So some of the more common ones you're going to run into, we mentioned rheumatoid arthritis. You have things like type 1 diabetes as an autoimmune condition against what cells do you think? Yeah, beta cells in the pancreas, absolutely. Multiple sclerosis, Graves' disease, thyroiditis, psoriasis, lupus, all these can be traced back to our body not really being able to tell the difference between ourselves and foreign antigens. So a couple of different disease states you can find here. Again, the only treatment for a lot of these disease states is to knock down the immune system. A lot of cases we're having to give specific antibodies that can actually target things like interleukin or tumor necrosis factor. Sometimes we're giving kind of big corticosteroid doses, so things that are kind of synonymous with cortisone, in order to depress the immune system. All of these things are going to have a lot of drawbacks to them, especially with the infection risk that comes about from trying to do that. So, when you're looking at a patient who's got rheumatoid arthritis and they're having severe joint pain, the question is like, okay, well, do I run the risk of them getting a secondary infection by treating them, or do they deal with this pain? And so oftentimes it's kind of a double-edged sword. You have to kind of walk that line between taking prevention, cautionary prevention against infection, and also treating their issue. So we'll run into this very frequently, especially in farm, as we get to that. Okay, and then real quick, we'll talk about allergic responses. The primary antibody related with this is, or the primary antibody is, IgE is going to be a big thing here. So again, this is going to be an abnormal response to allergens. Here's an example of a skin test that someone did who apparently has a lot of reactions. I find this all the time because we have an immunology department at Nemours, and so you'll have kids that will come in and on their allergy list will say pollen, mustard, cat dander, I don't know, germanium, like all kinds of random stuff on there. It's probably from these kind of skin tests that they do to detect what kind of reaction these patients would have to it. We'll find there's going to be immediate and delayed hypersensitivity reactions that can happen here, so it's important to distinguish between those two because they end up getting treated a little bit differently. I'm sorry?
Johnson, Timothy, they're allergic to people.
I don't know. I'm allergic to people named Timothy. Is there any Tims here? Oh yeah, so possible grasses or some sort of plant. Okay, there you go. Yeah, so types of grasses there. We used to do some of these. One of the things that we run into, at least from the clinical setting, is like we would have patients who would have like an allergic reaction to some drug. We would not know actually what drug it was, and so we actually have to go send them to the immunology clinic to actually and give them rapidly titrating doses of some of these different things to see what they actually had a reaction to. So this can come up pretty frequently, and the problem is like, especially if you have a patient who says like, oh, I'm allergic to a penicillin. What's the problem with that? Can never use a penicillin on them ever again. And so that's one of the things we can actually do is to detect, okay, do you actually have a penicillin allergy or not? And so you can do tests kind of similar to that to see if they actually have a reaction, or if they just had diarrhea and they forgot about it and they think that's an allergy, which is not the case. So looking at immediate hypersensitivity, what can happen here is you have abnormal B cell responses to some sort of allergen, whatever kind of foreign protein or molecule happens to be. The effects are going to happen within seconds to minutes after exposure. And so these are the things you see when caused by foods or bee stings or pollen or anything like that. These are going to be immediate hypersensitivity reactions. And so what you end up finding kind of downstream from this is you're going to have the helper T cells that are going to start to secrete some of these lymphokines like interleukin 4, interleukin 13, and these are going to stimulate B cells and also plasma cells to secrete IgE. And the IgE is going to cause kind of downstream further reactions. You're going to start to see these mast cell degranulations, and this is where you run into a lot of the problems we'll get into in just a few minutes. We'll see. So again, looking at this, an allergen will be detected by the B cell. That can then eventually lead to activation of some of these plasma cells, release of the antibodies, and that can then affect these mast cells. We said these are going to have these granules that are full of inflammatory cytokines, like things like serotonin, histamine, all those things. So you can either have activation through that pathway, or you can have the mast cells actually degranulating in response to the allergen itself. So both of these processes can happen here with these immediate hypersensitivities. So then once you see the histamine and other chemicals released, that's when the actual allergic reaction is happening there. So, and how would you treat, yes ma'am? Basically, those mast cells contain like just a ton of different inflammatory cytokines. So things like histamine and serotonin, platelet-derived growth factor, all kinds of different things get released out of those granules, and that's what leads to the allergic reaction itself. That's one of its primary uses, is to kind of help that with the activation of those mast cells. I think it's just the cell receptor. Right, it's just really the cell receptor that's kind of activating there. That's kind of the primary thing you see with that. So, and again, this is the one that is disproportionately going to be expressed in allergic reactions versus any of the other immune globulins you're going to see there. So, actually detecting levels, that would be what you're seeing. So how would you end up treating one of these reactions? So you'd probably do something to block histamine, right? So you use like antihistamines. You guys know any antihistamines? Yeah, Benadryl is a really good one. So we'll give like IV Benadryl. What else can we give? Steroids. Yeah, steroids are really good because that helps to decrease a lot of that production of new inflammatory cytokines and things like that. So that can be really useful there. Anything else we can give? Yeah, epinephrine. No, epinephrine is going to be one of the go-to drugs, especially when you have a lot of like tissue swelling. Again, the airway closing is one of the big risks we run into with people with true anaphylactic reactions, and so we can give them epinephrine to help try to constrict those blood vessels and reduce that edema that happens there, right? So kind of directly affecting the effects of like things like histamine. So those would be an immediate hypersensitivity reaction. And then you have your delayed hypersensitivity reactions. This is going to be abnormal T cell responses that produce symptoms, say, 24 or 72 hours after the actual exposure itself. So it may not be apparent at the time of the actual exposure. Symptoms are going to be caused by that secretion of lymphokines, not really histamine related so much. But so in this case, taking histamines really doesn't have a whole lot of good effects here. Okay, so this is why you use things like topical corticosteroids, things like cortisone or hydrocortisone after you've been exposed to things like poison oak or ivy. So like a contact dermatitis like this is going to be a delayed hypersensitivity reaction. And again, things like epinephrine, histamine, and histamine blockers are not really going to be good here. Really, only steroids can be useful to help decrease the production of a lot of those inflammatory cytokines. Okay, kind of big difference there between the treatment aspects. Okay, so just kind of showing comparison between here. So again, time to onset for immediate reactions obviously going to be within several minutes versus within days for delayed reaction. Lymphocytes are primarily going to be the B cells that get involved here in the immediate reactions versus T cells primarily in the delayed reactions. IgE antibodies are going to be the main thing here with immune effectors versus that cell-mediated immunity through those T cells. Going to be primary in the delayed reactions. And then oftentimes you'll see like food allergies, asthma, things like that are going to be mediated to this immediate reaction versus contact dermatitis is probably the most common example of a delayed reaction hypersensitivity. I mentioned therapy here, antihistamines, adrenergic drugs, steroids will also be involved in this versus just corticosteroids here for the delayed reaction. So they use like hydrocortisone cream and things like that for poison ivy. They, yeah, they're not going to be like life-threatening like that, at least in the cases I've ever seen. They're typically just more really annoying and kind of affect quality of life more than anything. All right, so that's it for the immune system. Any questions on that? Yeah, so on that one, what slide was that? I'm sorry, there's a correction I had. SUP. RESSOR. Stand by. 51? Okay, if you go to 51 and 52, I meant to say killer T cells there, not suppressor T cells, as was brought to my attention. Thank you for correcting me. I'm sorry? Does it say like suppressor? Yeah, that should say that should just be say killer T cells there. Yeah. I apologize for the typo. Huh? 51? Yeah. Okay. Sweet. All right. That's the only correction, right? All right. I think that's it. Okay, so we're gonna go into the next.